Flow diversion is been with us for a while now, and it's here to stay. I think flow diversion is an excellent procedure to treat many aneurysms, mainly the side wall ones, in the carotid, but more and more in the last several years we've been using it even more distally in the bifurcation aneurysms and the small vessels as well. So it's one of the most important advances that we've had in our field, flow diversion.
Why would you choose, what would make you choose not to use flow diversion?
Dual antiplatelet therapy, which is required for all flow diverters, is a drawback. But otherwise, you could argue, I mean, the cost as well. These stents are very expensive. But otherwise, you could use flow diversion in a lot of aneurysms these days. Yeah. The indications are expanding every few years.
So if you're faced with a patient who has a high bleeding risk, what would you choose to do?
It depends on the location of the aneurysm. So if it's in the carotid siphon or above, below the bifurcation, if it's a wide neck aneurysm, I would choose to flow divert it. If it's a very large aneurysm, I would probably coil it and flow divert it. There are aneurysms which are in the bifurcation, like middle cerebral aneurysms or anterior cerebral aneurysms, where I'll probably choose an intrasaccular device, web or contour, instead of flow diversion. So location, size, and also the ability to put the patient on dual antiplatelet or not. We've got a vast experience with the web, and we also, more in the last few years, we've been having more and more experience with the contour device. The web device has been an excellent addition to our armament, both in the acute setting and also in the elective setting. But also contour has added more to that, and now we have a variety of devices we can use intrasaccularly.
Do you find them relatively easy to use?
Much easier to use, quicker, less radiation. There is obviously the issue of sizing, but there is more and more 3D and AI equipment that can help us with that.
When you use those type of devices, is there the risk of the aneurysm coming back again?
That's always the case with any device, whether you coil, you put intrasaccular, both are associated with a certain degree of recurrence. But that recurrence can be minimized and can be managed. So the small recurrences we don't worry about. If it's a large recurrence or if it's a growing recurrence, then we treat it. So recurrences is part of the solution, really, in a way that they will happen. No matter what you do, you will see recurrences. I don't think in the hemorrhagic section, I don't think there is an unmet need yet. Yes, there are improvements that can be made on the current devices, but there is no aneurysms that we think this is impossible to treat with any device. There are like dolcectatic changes which are difficult and complicated and everyone struggles with, but then the treatment of these or the indications are very limited. But in terms of do we lack devices to treat our aneurysms, the answer is no, there isn't. There are devices better than others, but overall I think we have enough to treat the majority of aneurysms.
Drugs, change in the way DAPT is used?
Yes, I mean the use of drugs like clopidogrel has caused us problems. The introduction of newer antiplatelet therapies has made treatments safer. So definitely drugs have reduced the complication rate for flow diversion in particular.
And needed trials, or do you feel you have the data you need, or is there data you're missing?
Well, there are trials happening. I'm involved with the coating trial, for instance, which compares single versus dual antiplatelet in flow diversion with the P48 and the P64 HBC. So trials are on the way, but trials are not always the answer to our problems. Obviously, having a proper registries and very strict account of complications and all the rest of it is very important. But we do need certain trials to lead us into what's the best way to manage, particularly with dual antiplatelet therapy. But I think overall we are in a much safer position now than we were 10, 15 years ago.
Well, the key now is probably sharing the information you have, but also then training. And,
yes. Training improved, devices are better. And obviously technology has been there for a long time, and we've always adjust and improve, and you come to meetings like this where you learn a few things, you share your experience, and that in itself reduces your complications in the future. So
yes, you combine the experience of others.
Correct.
Do you have any last comments you would like to make to the LINNC online audience?
It's been a great meeting this year. I enjoyed it after all the restrictions and the COVID situation that we all came through. We're lucky to survive all of this, and we're even luckier to meet again.